So hopefully everybody can hear me. I'm Sean Lyden. I'm the chairman of vascular surgery at the Cleveland Clinic. Can I get my next slide? These are my disclosures. Next slide. So, I'm a surgeon. I do both TCAR, I do carotid endarterectomy, I do carotid stenting. I trained at University of Rochester, where Charles Robb came after he'd done one of the first carotids in England. And so he was on the wall there. So I've trained at an institution where really carotid disease was developed in the United States. Next slide. Here's just an operative picture. This I took from Norm Hercher, who was the chair 15 years ago here at the Cleveland Clinic, and we still do it in exactly the same way now as we did then. So we may or may not put a shunt in. We scrape all the plaque out. Next slide. Once we're done, we may or may not tack down the endpoint. You can see how clean it looks, and then we patch the artery to restore it to normal size, or we'll divide it and evert it and complete it as an eversion artery. But for the most part, carotid surgery is identical to the way we've done it for almost 30 years. We do more people under local, and we have better anesthesia techniques using narcotic-based anesthesia, and so the outcomes have improved, but the surgical technical aspects are pretty much unchanged. Next slide. So what are the advantages of surgery? Well, we can deal with really dense calcium. If it's a really tortuous arch, we can deal with that. We can do people awake or asleep. When I first got to the Cleveland Clinic and we were leading in carotid stent technology, we had a summit with CEOs from everywhere. And I remember I got asked, would I do a live case? Jay Yadoff was doing a carotid stent on one camera. I was doing an endarterectomy on the other camera. And he goes, now look, my patient's awake. How great this is. And everybody goes, ooh, ah. And I said, hey, wait, look, my patient's awake too. Look how awesome this is. So you can do it either way. And it's got great long-term data. What are the downsides? Well, there is definitely a higher heart attack risk. And we first saw that when we first started doing the carotid stent trials with the Sapphire trial. And we know patients do have cranial nerve injuries. When we look at registry studies, they say they're 2 to 4%, but when you get independent neurology evaluation, they're definitely higher. Next slide. So TCARs come along, and TCAR basically is a small cut down the neck. So it's still surgery. It can be done under local or general anesthesia. And interestingly, most of it in the United States is still done under general anesthesia. And the difference is, instead of now cleaning out the artery, you're getting basically the equivalent of 11 French sheath in, and then drawing blood out of that sheath and then returning it through a femoral venous sheath, basically using passive reversal flow for protection. Next slide. So TCAR has really gained the huge interest of the vascular surgeons. And I hope none of the investors are vascular surgeons, but what I'll sit there and tell you, I think it has enabled the non-skilled interventionalists to do carotid stenting, because one of the riskier parts when you're learning how to do carotid stenting is coming from the groin and getting into the carotid safely without producing a stroke. In the original carotid trials, the ACAS and NASAT trial, the angiogram alone produced about 1% of the strokes. And right now, if you're involved in the Vascular Quality Initiative Registry, you can do TCAR in patients. And so that registry is allowing the treatment of 40,000 patients in that registry, and it has grown leaps and bounds. The early results would suggest it's about as good as surgery. However, it's not a randomized study. So there are patients who you can't treat with surgery that you can treat with TCAR, and there's patients you can't treat with TCAR that you can with surgery. However, there's still cranial nerve injury. It's still an incision, and you can cause damage to the common carotid artery. So it is a great adjunct to what we have, but I don't think it's going to replace surgery in the long run. And I think most patients, if they had their choice and didn't have to have an incision in their neck, still wouldn't want it. Next slide. So what are the advantages of TCAR? Well, it's covered if you're involved in the Vascular Quality Initiative Registry. If you're not, you still can't do it. It avoids the arch, and someone for a bad arch, that's awesome. I think it clearly allows easier access for less skilled interventionalists. And if you have a really tortuous internal carotid with a loop-to-loop, you don't need that distal filter. I would also say that Dr. Metzger, Dr. Seek, and I myself would also say that that's where the MoMA comes in. But it has been shown to have a very low learning curve. And so unlike carotid stenting, when we first started in the early 2000s, where there was a pretty steep learning curve, TCAR has been adopted pretty quickly with not a large learning curve. Some of the limitations, you need at least 5 centimeters from the clavicle to the internal carotid origin to be able to get that TCAR sheath in safely. You can't have a big disease common carotid artery. You can cause some dissections of the common carotid. You still need an incision and you still have cranial nerve injury. And my other job in life is I was the medical director supply chain for the Cleveland Clinic, and I'm still the chief medical officer for our GPO Accelerate, and it's expensive. And so it costs a lot more than stenting or surgery. Next slide. So carotid stenting, well, we all like it, we do it, and we waited forever to get it in the US. The problem was in the early 2000s, there was a huge fear of use and abuse, and the surgeons, which I'm part of, were terrified that it was going to take over one of our last bastions of things that we only controlled. So because of the dispute between the surgical and interventional community, it was limited by Medicare to only approved trials and for approved devices. And we've all seen how this has limited the use of the technology and the dissemination of the technology. Next slide. So in 2005, it was really the first time CMS, to my knowledge, really had the global non-coverage policy. So it really limited carotid stenting to ID trials, and it limited to 70% symptomatic stenosis in high-risk patients with approved devices. So you can still be in a category B trial, but you had to be a site that had approved competency in carotid stenting, and we had to report our outcomes. Next slide. So you can only do it with approved stents, approved devices, cleared embolic protection systems. And if you couldn't get the embolic protection system in, CMS doesn't pay you. Now, maybe at some institutions, it's not a big deal. This is a big deal at the Cleveland Clinic. They're not real excited when we do things for free. And so if patients don't meet those coverage policies, we either have to get them to sign an advanced beneficiary notice saying they're going to pay the whole bill, or we don't do it. Next slide. Hit the next slide. So CMS has said what's high risk, and so I'm not going to go through this, but you basically have to have a bad heart, bad lungs, a high lesion, a low lesion, or prior surgery, and you have to be symptomatic with a non-disabling stroke. So that sounds like not too big a deal, right? Next slide. The difference is it limits to what we do. And in my practice at the Cleveland Clinic, it's about 5 to 8% of our patients who qualify. Now, in 2007, industry and physician leaders wanted them to add asymptomatic greater than 80% to high-risk coverage. We also offered mandating a surgeon evaluation and no coverage for those above 80 when the early CREST data suggested that maybe the older patients wouldn't do as well, and no coverage of protection device use. But really, CMS sort of rejected all that. They basically said you still have to use emboli protection and rejected all those other suggestions. Next slide. So where do we sit today in 2022? Amazingly, no different than we were in 2005. About 10% of my patients qualify. It's the only disease process I do where once I decide the best way to treat my patient, I have to look down the sheet and see what they have for coverage. And so if they have private carriers, some of them will mirror Medicare, some of them will mirror the FDA labeling, and some just say it's all experimental and don't cover it all. And the reality of what this has done, it's stifled innovation in this space. Next slide. But what's changed? Carotid stenting, despite that, has undergone the most scrutiny of pretty much any therapy I know. And the difference is, since the last time we asked to change the coverage decision in 2007, there's been 4 large multi-center randomized trials with almost 7,000 patients showing equivalence to carotid endarterectomy in both procedural outcomes, long-term stroke prevention, and durability. And I think we also have gotten really good as physicians in knowing who best to apply that technology on. Next slide. If you look at over time of all these trials, you can see the trials from the early 2000s to now, you can see that the procedural stroke and death rate has continued to improve because we're getting better and better at figuring out who to use the technology on. Next slide. We spent forever trying to talk about closed cell and open cell. And as Chris and Adnan talked about, closed cell has better area of coverage, so there's not as much area that the plaque can come through, whereas open cell tends to have a bigger area and it allows for better conformability to the wall. So in closed cell, all the cells are connected. They're smaller cells, but it tends to be stiff. So in a tortuous artery, it doesn't work well. And in an open cell design, some of the cells are connected. There's larger cells, so the ability to prolapse, and they're more flexible. So most of us have gone to say, well, some of the data suggests closed cell designs are better for stroke prevention. And so we generally use that anytime we can, or in straight anatomy, and open cell if it has tortuous anatomy. And unfortunately, there's no ideal stent, and there's been this debate going on for 15 plus years. Next slide. So, my opinion and many experts is that carotid stenting now should be not just for high-risk patients. From the CREST outcomes stratified by symptoms, we know that for greater than 50% symptomatic and 70% asymptomatic patients, there was no difference between carotid stenting and carotid endarterectomy for the primary endpoint of death, stroke, myocardial infarction in either subgroup. It was 5.2% versus 4.5% with a hazard ratio of 1.18. And you can see the confidence intervals. And there was almost 1,400 patients that were symptomatic and almost 1,200 asymptomatic patients. So a humongous trial that has reported outcomes. Next slide. Since that last update, there's a bunch of new trials. So the difference is now we have the really long-term outcomes from CREST. Act 1, which was a randomized trial, surgery versus stenting, really once again showing no difference. The SPACE 2 trial, carotid endarterectomy versus carotid stenting in medical management, no difference. And the ACS2 trial just reported last year with almost over 1,800 patients in both arms with, once again, through late outcomes, no difference. Next slide. So if you look at that, we now know Act 1 data up to 5 years, and you can see that any procedural stroke for carotid endarterectomy, carotid stenting, no difference in the p-value. SPACE 2 through a year, no difference. ACS2 through 5 years, no difference. Next slide. So what do we know now? We know that if we look at their arch, if it's really that the artery comes off at the top of the arch, it's easy to get into. So the far left screen would be a type 1 arch. The far middle screen would be more of a type 2, where the far right screen would be a type 3. So this would be one that only someone with a lot of skill might undertake, or you might be able to do surgery on this patient or TCAR. Next slide. We also know that if there's clot in the arch, or if there's a bad arch, you can still stent people, but it's a lot harder. You're going to have a lot more difficult risk. You can see in this patient that the sheath has kinked. Now, the delivery of any of your protection device is going to be much more difficult with a higher risk. Next slide. The other thing we know is that what are your landing zones? So you can see a patient here where the external carotid is out. So then using the MoMA or trying to get your sheath in is a little bit more difficult, but not undoable. If the patient has a very straight landing zone, that's also great. But if there's a loop-to-loop or tortuosity, then trying to place your filter in that is going to be more difficult with more fraught complications. Next slide. And we also know that if it's densely calcified, like this picture on the left, if it has ulcerations like the middle picture, or if it's really, really tight like the picture on the right, that portends to a higher risk of adverse events with carotid stenting. And skilled hands still can be done safely, but higher risk. Next slide. So what's the advantage of carotid stenting? Definitely has a lower MI rate. I'm a surgeon, but it doesn't take anybody to convince a patient no scar or a scar, percutaneous is better. It has equivalent risk of stroke and death to carotid endarterectomy, has an equivalent risk of restenosis to carotid endarterectomy, and the best times of anatomy to treat, I think, are well defined. We're much better at it. Both distal and proximal embolic protection works. We also know that still densely calcified lesions aren't perfect. Transversing the arch isn't perfect. And what we talked about, you heard from Dr. Metzger and Dr. Siddiqui, we know that we can have post-dilatation to get the artery open, but that's the time of most embolization, and that plaque starts to protrude through a stent, but that embolic risk continues, as Chris showed you, for some time afterwards. And we know that it leads to both silent brain lesions by MRI that are higher than carotid endarterectomy. And the problem is that up until about a couple of years ago, in the United States, there's been no real development. Next slide. So if we look at some of the approved devices, whether open cell or closed cell, and you look at the area for a piece of plaque to go through, you can see that if you were a circle plaque, they're all about the same, but that's in a straight artery. If you start having a bending artery for an open cell design, that plaque starts to have a bigger area to go through, but there's not a big difference in the large inscribed circle between the closed cells to the open cells. But if you start having some tortuosity, that can make a difference. Next slide. So what's got me excited? It's the Micromesh stent technology. There's been 3 versions that have come out, but they're not all the same. So some of them elongate and then have to foreshorten when you place them and don't necessarily oppose the plaque really well. Some of them have had higher thrombosis risk. And I'm not going to go through the same data that either Marvin showed you or Chris or Anand showed you, but this Micromesh from the CGuard from InspireMD is the largest amount of data set out there. Next slide. So we've heard that from Crest that surgery is equivalent to stenting. But amazingly, they've even spent time trying to study their stent, the CGuard stent, against the AccuLink stent, which was the stent used in the Crest trial. And so if you look here, when people had CGuard or AccuLink in a randomized study, there was much less event rate in it. And so not only do you say, well, we have a registry comparing one to the other. This was actually a trial looking at the 2. This was just published last year in JACC Interventions. And I think this is one of those studies that really got me excited. And I think this is where this company is very well positioned, because hopefully we'll have this stent approved in the United States soon. Chris is a national PI. Both Adnan and I are sites. I've used this clinically. It works really well. I've seen the data from Europe. It was very strong and powerful. But the advantage to me of the Micromesh stent in this design in particular, it conforms to the vessel because it's basically an open cell stent design. It's going to stop plaque protrusion, not only at the time of post-dilatation, but outside of that because of how tight the weave is. Next slide. There are other technologies out there. One's a NeuroGuide protection device. And so that puts a second filter in, and then you deploy the stent and you can post-dilate the stent. That will help protect any emboli while you're ballooning and placing your stent. But as Chris showed, a lot of those events happen later than that. So although this is a new technology, hopefully to address some of the needs, I don't think it's going to have the impact that the Micromesh stents do, because it's only going to help stop issues right at the time of stent deployment and post-dilatation. Next slide. So where are we at? I think carotid endarterectomy and carotid stenting has matured. I agree with Chris. There's a lot more enthusiasm for carotid stenting now. And I believe, and we're pushing to get CMS to relook at the NCD to cover for both greater than 50% symptomatic and greater than 70% asymptomatic patients, just like they do for carotid endarterectomy. I think we've really spent a lot of time defining who best to use carotid stent technology over the last 20 years. TCAR is a great approach. It does have a role. I'm not a huge TCAR enthusiast, but a lot of my vascular surgery friends use it almost more than surgery. And so the guess part is this stent technology can be used there too. And we've clearly seen now in the last year with this company advances in stent protection strategies. And I think that's going to continue to improve our outcomes. And so we definitely now know that the Micromesh in some versions are better than the standard stents. And I can say the 3 of us are all excited to hopefully have this in our hands to use as we want, how we want in the United States soon. Thank you.